We're live.
Okay, we'll allow a little bit of time for the room to populate. So welcome, Matt campers. Okay, I can see this flow of people beginning to start, so I'll get started. Welcome again and good morning, Matt campers. We have a really interesting talk to get us going this morning. Really appreciate you all attending. As you all know, this is a community-driven and a community-powered conference. So it's a pleasure of mine to introduce the first of our resilience and recovery track. We have an experienced mapper and previous MAP camp attendee and speaker in Sarah Mackie. Sarah Mackie actually teaches at a university that I am an alumni. So really excited to have you here, Sarah. Sarah's going to be talking to us about how are we going to get better. So you are in the resilience track, and this is the Crystal Cavern room. The theme for this talk is just how are we going to get better? The context behind this talk, for those who aren't in the UK like Sarah and I, we have a new government after 14 years of a previous government. Healthcare and the way that our National Health Service has been run is really a major national conversation at the moment and an opportunity. So Sarah's right at the forefront of that. Talking to us, the title is Involving Patients in Healthcare Improvement Work. So Dr. Sarah, why don't you tell us a little bit about yourself, your background, what inspired this talk, and what you're going to tell us today about how we can get better.
Great. So thank you so much for that introduction, Damien. So my name is Sarah Mackie, and I am a medical doctor. So I'm a rheumatologist, which means I look after people with inflammatory joint diseases, and I work at Leeds. Now, I'm a funny sort of doctor. I'm a clinical academic, so that means I spent half of my role is spent on research, academic work. The other half of my role is in delivering clinical service. So I work as an honorary consultant for Leeds Teaching Hospital NHS Trust. My training as a clinical academic has been very, very academic focused, which is absolutely wonderful and has been the most amazing journey. And then you get to be a consultant, and you have this 50% of your time. And they say, so right, we now want you to also improve our clinical service that you are in charge of, and this is part of your job. And the teaching and training that we get for this as doctors is quite limited, because they're focusing on training us to do our job, to treat diseases, and methods for healthcare improvement, and particularly in how we involve patients, the public. That's something that doesn't get quite so much attention in our training. And so I want to share a little bit about what I've learned through experience in my role about how you can involve patients in healthcare improvement work, and how mapping has helped me in that, and some of my story and my journey through that. So I'm going to talk a bit about what I mean by service improvement work, about what we mean by that in the health service, in the National Health Service in the UK. I'm going to talk a little bit about the disease which we're talking about today, which is giant cell arteritis, which is quite a rare disease that you may not have heard of. I'm going to talk a little bit about corticosteroid therapy, which you may have heard of, which is the mainstay of treatment for this disease. And then I'll go on to talk about how we use mapping to prioritise what to improve in our service, and the difference that mapping has made so far to me in my role as a doctor and as a researcher. So clinical service improvement, very simply, in the health service, we sort of have two sorts of activity that sort of looks at groups of patients. We have clinical research, where we're looking to understand the causes, treatments, and outcomes of disease, and we're generating new knowledge, and that should be generalizable knowledge, which we hope will help people in other places. But service improvement is about making the clinical service better where you are, where you work, in your local context, and it is always a ground up activity that needs to involve the whole team, and is really looking at, how are we actually going to deliver this service and make sure that we deliver our clinical service as efficiently and as effectively as possible given the resources we have. So the standard method that we use for this is the PDSA cycles, which was introduced by Deming and is really popularized by the Institute for Healthcare Improvement. That's PDSA. It's also called PDCA cycles as well, and it comes from Lean. And it's an iterative process where you decide what to do, you do a thing, you collect data to see what happened, and you learn from that data, and then you do another thing, and you just keep improving, and it's these small steps to change. And healthcare improvement is different from research, which is this big splash thing where you discover a new thing, and it's more of a process, and it's an iterative process. So my journey along healthcare improvement has been iterative and small steps, just like the approach to healthcare improvement that we have. So giant cell arteritis is the disease that I did my PhD on. And I'm going to tell you a little bit about that now. It affects older people. It's really the most average age that you will be diagnosed with giant cell arteritis is the age of about 75 years old. And why is that? Well, as we get older, our immune system changes. It's influenced by everything that it encounters during the lifetime, even since while you're in the womb. And we call this whole thing the exposome, everything that the immune system sees and does over the lifetime. And as it does that, it remodels, it adapts. And as we get older, the immune system may become less resilient. So it may not be able to respond to stresses in the same way as it does when we're younger. And the immune system is involved in many age-related pathologies. It's certainly involved in cancer, and Cancer Research UK is one of our sponsors for this conference right now, but it's also involved in many neurodegenerative diseases, and potentially including Parkinson's as well. And we know also that immune aging may well play a role in cardiovascular, age-related cardiovascular disease, atherosclerosis. But my area of interest is in autoimmunity and immune-mediated inflammatory diseases. So the immune system, as it gets older, this immune aging or immune senescence, it can get a little bit trigger happy, and it can turn against the body itself, and that can cause inflammation. And in rheumatology, we treat a variety of diseases which we define according to the bit of the body that becomes inflamed. So in giant cell arteritis, it's the arteries, the blood vessels that become inflamed. It's linked with another condition called polymyalgia rheumatica, where there's a big overlap between them, and they exist on the same spectrum. And in polymyalgia rheumatica, it's not the blood vessels, but it's the ligaments, tendons, joint capsules, which causes stiffness, so people cannot move. If your blood vessels become inflamed, then this thickens up the inside of the blood vessel, so the blood can't get through. And if this affects the blood supply to the eye, this can cause blindness. If it affects the blood supply to the brain, this can cause stroke. So giant cell arteritis is potentially a very serious disease if it's not treated. We need to diagnose it promptly and treat it early. And I've put here some references which are written for doctors, but you can take a look at them and look at the current state of medical knowledge about these two diseases at the moment. So these blood vessels and these tendons and ligaments, joint capsules get inflamed in particular patterns, and we use this to diagnose the disease, and we recognize patterns, and we know that particular diseases respond to different treatments. But the mainstay of treatment for both these diseases at the moment is corticosteroid therapy. So we sometimes call this steroids for short, but it's not the bodybuilding sort of steroids that make your muscles big. These are drugs related to the hormone cortisol, which our body naturally produces as a stress hormone, and it does a lot of things. But one of the things it does is it dials down the immune system to give the body a chance to run away from the tiger, whatever it does in that moment of stress. And this therapy, these drugs, mimic very closely cortisol, which is naturally produced from the body. And they brilliant drugs for that. They can save lives. In giant cell arteritis, they can save sight, they can prevent visual loss. And in people with polymyalgia rheumatica who can't move because of the inflammation around their joints, they can then move again. They can now get out of bed, they can get up from the chair, they can turn over in bed, and all those things they couldn't do when the inflammation was active. So these are marvelous drugs for this. They quench the inflammation. But cortisol does a lot of other things as well as quenching inflammation. And so there is some what you might call collateral damage. So it's important that we put out the fire, but we don't want to sink the whole ship in the process. One of the issues is that in reducing the reactivity, if you like, of the immune system, then it makes the person more vulnerable to infections. And this is an example of a recent study from Denmark, which is population-based, and it uses healthcare records, and it's looking at admissions with infections. And there's a 2.7-fold risk in the first year of diagnosis after giant cell arteritis of being hospitalized with an infection. And that's because this treatment is not just a short-term thing, but patients continue treatment with steroid therapy for a good year, often 2 years or more after diagnosis, to really quench that inflammation and make sure it stays away. And then during this treatment, there's an increased risk of infection because these are older people, they're already vulnerable to infection. So the base rate, the comparators, is 6%. So 6% of people without giant cell arteritis were hospitalized over over this time period for infections. These are matched controls, so people who are the same age and sex as the people with giant cell arteritis. But then there was people with this disease, 18% of them were admitted to hospital with an infection, and the adjusted relative risk was 2.7-fold. So you can read a little bit more about that on this link here. And it's not just infections, but corticosteroids have all sorts of other side effects that are listed on the product information. And these the side effects which may affect some people, most people get at least one side effect from the list of potential side effects of steroids, and this includes hunger, which can cause weight gain, can really disturb sleep, particularly at high doses, and can cause anxiety. Rarely, corticosteroids can cause psychosis, which can be quite difficult to treat. They can put blood pressure up, they can induce diabetes, they can cause progressive cataracts, they can cause glaucoma, and glaucoma, if it's not picked up early and treated properly, then that can cause irreversible damage to the eye. They can cause fragility of the skin and fragility of the bones. So steroids cause loss of bone density, and once that is lost, that's difficult to get back again later. And so there's a fracture risk which persists even after the steroids have been stopped. And this is also a problem, of course, for older people who are already at increased risk of bone fracture because of the aging process. And then lastly, the production of cortisol by the body is very tightly regulated, and the levels of steroids are sensed by the hypothalamus. And if it sees that the person is taking lots of corticosteroids as a drug, it doesn't bother to make its own steroids, and we cause adrenal insufficiency. And this can cause various other knock-on problems later on down the line, because at some point, as you taper down the corticosteroid dose, the adrenal gland has to remember how to make its own steroids, and sometimes it can be not quite as prompt at doing that as we would like. So there's lots of unmet needs for this patient group, because we're really good at treating the inflammation most of the time, but the treatment can cause some problems of its own. So we're here diagnosing these patients, treating with this medication, but not only does the disease need monitoring, but the side effects of the medication really need monitoring. So it's quite a complex problem. But a lot of it all comes down to diagnosis. So the first thing we did in improving our service is in delivering the existing guidelines, implementing the existing clinical guidelines. So around 2020, some new guidelines came out that I was involved in writing, which showed that there was a better test for diagnosing giant cell arteritis. So as well as the traditional method, which is a temporal artery biopsy, where we actually take out a little bit of the artery and we sew off the ends, and we send that artery off to the lab and look at it to see whether there is the histological evidence of vasculitis. An ultrasound scan can be used to diagnose the disease with equivalent diagnostic accuracy to temporal artery biopsy, but faster, more cheaply, and in a more cost-effective way. And at the time when I started improving the service in 2018, we weren't doing that systematically for all patients in Leeds. So we went through a process of service improvement to introduce that test. And these amazing people here is Harjit, Borsha, and Kate, who are our sonographers, who are the people who have been doing those ultrasounds for us over the last few years in Leeds, and have really made a massive difference to our whole service by getting diagnosis right. And there have been more recent recommendations really sort of highlighting the value of this test as a diagnostic test in the pathway. And I talked at MAP Camp in 2022 about in a bit more detail about our process of implementing this test and mapping out, really for myself at that time, the value of this test. And most of the guidelines talk about the individual level value, so the value of information you get from this test in making clinical decisions, and that's really, really important. And without that, there wouldn't be any point in doing the test at all. But there's additional value add for introducing a test like this, which really is only evident at system level, and you can see this really clearly if you Wardley map it out. And what we discovered was that a lot of the existing methods of diagnosing, so not just the imaging, the scan itself, but the eliciting symptoms and signs, interpreting the biopsy, interpreting blood tests, all of these really depend fundamentally on the expertise of the clinical team that's doing the diagnosis. So that's doctors and everybody who works and supports with those doctors. Everyone needs expertise in knowing how to interpret all these different sorts of clinical information. And imaging is part of that, but not all of that. And because the ultrasound can be done so quickly, whereas biopsy was taking about a month for the results to come back, because the ultrasound result was coming back so fast, the people who were requesting the ultrasound got really fast feedback, yes, no, on whether this patient had the disease or not. And this really helped us learn as clinicians how to recognize these better. So it helped us from our expertise, our pattern recognition, and so the whole team got skilled up in a way that we had not predicted just from looking at what the guidelines were saying about this test. And so that mapping really helped illuminate to me how these things, there's an interplay between these things, and we kind of had a virtuous cycle in everybody who was involved in our MDT, which we had set up really to keep things safe, to check that the imaging was in fact giving the same result as the biopsy. It had this unintended benefit of really informing the clinical experience of everybody who was involved. And we went from not doing ultrasound at all to now we're really happy with how it's used, and a lot of the time patients don't need biopsies at all because the ultrasound, symptoms, signs and blood tests provide enough information to make that diagnosis really fast, get patients on treatment, and get them on that treatment pathway so that we can move them through to that monitoring phase. So that was all great, and we were so pleased, and we even won an award from the British Society of Rheumatology called one of the Best Practice Awards in 2022 for the way in which we managed to introduce this test, which was recommended by the guidelines, into our service. So then what next? So the next step was not so obvious because we'd implemented the guidelines. This was always good. So what do we do to improve next? So I was during this time, I was having a few conversations with a colleague of mine who works, she's a professor of health psychology. She's called Hilary Becker. And one thing which has really stayed with me about that conversation, she said, well, Sarah, you have to beware of this because you're a clinician, and clinicians are always very tempted to introduce the machine that goes ping. So this is a reference to a Monty Python, sketch, which you can go up and look on the internet, but essentially the machine that goes ping is your very high-tech, exciting technology, which is often sort of very novel. It might be developed by a commercial partner, and it's very exciting and people love to talk about it. And in the middle of all of this sketch, the patient says, well, what do I do? And they say, oh, nothing, dear, you don't have expertise, you don't have to do anything at all. And the patient's kind of at the center of this thing, and the machine is foregrounded, and the poor patient is in the background being the patient. So she said, well, beware of the machine that goes ping. Sometimes what you want to improve is introducing your machine that goes ping is not always the obvious solution, and you can have these very complicated pathways to improvement, and you can spend lots of time designing them and sketching them out, but ultimately you really have to understand what are your patient needs and what are the needs of your staff. You need to understand your user needs. So at the same time, I was taking part in Simon Wardley's 2022 healthcare mapping project, which was part of a series of linked projects that he was doing to map out different sectors. And he's very helpfully put a quite nice post on LinkedIn describing some of that work on the healthcare group that I was working within. And I was really struck by the power of this technique in really foregrounding benefit to society. And we ended up with this prioritization exercise and contrasted the results of that with what analysts were saying, and really, the noise that was being made about healthcare, which was driven more perhaps by focus on the market and where there was money to be made, rather than necessarily what was going to help societal benefit. And I was really interested that the things that came out top in this prioritization exercise, which involved sort of actually measuring, really making people better, how we're measuring patient outcomes, and how can you do that without actually getting some data from patients, asking patients to report how they are feeling, how is their health, because if you only ask clinicians whether they think the treatment was a success, you're missing a dimension of health, which is really important. And that data needs to be shareable, it needs to be high quality. And I was thinking back to my problem that I had in the other half of my, healthcare improvement half of my job, and how dependent that is on secondary use of medical data in order to actually drive that improvement cycle. Because if you can't measure whether you have made a difference, and you can't use that data and analyze that data and have trust in that data, then you can't progress around that improvement cycle. You can't make things better. So I was really thinking about how, yes, data is important and patient relevant outcomes are important. And in order to understand what's relevant to patients, we have to ask patients. So I think I was within one of these sessions, I was talking about my problems of, where do I go next with my sort of improvement exercise? And I think saying, oh, well, of course, we could ask patients, and we've done patient and public involvement for our research, so we could do the same for this, and then of course we have to go back and talk within our team. And I remember having a conversation with Simon, and he was saying, well, why don't you just get people together and get them to map the landscape together? And I sort of thought, oh, this sounds really hard. How do we get patients and staff in the same room and talking together? This is not what we normally do, because most patient and public involvement work, we do a lot of this in Leeds, and the heritage of this comes out of consumer research on the one hand, so focus groups and surveys, and also social science as well. And with all of these things, the patients are the subjects of inquiry. They're not necessarily active partners in what's happening to the same extent as the researchers. There's this differential between the researchers and the patients. But I'd also experienced work within an organization called OMERACT, where we have been looking at developing outcome measures for clinical trials, and we have a very strong patient involvement, and patients are actually considered partners in this, and we call these patient research partners. And having led an OMERACT group, I was really struck by the power of that, of having patients and clinicians in the same room together talking about problems. And we've done this for outcome measures for clinical trials, so could we do this for a clinical service? So by this time it was post-pandemic, and although we do have quite a lot of older people in our patient group, many of them had been using Zoom very nicely during the pandemic to talk to their family and friends. So we now had at least some of our patient base were able to talk, engage online, which was great. And we also, because we do a lot of research in Leeds, we have a really strong infrastructure for patient and public involvement. So we had a mailing list of people who said they'd be willing to be contacted to help advise on new research in their condition. And so we sort of put a shout out to say, we're looking for people to come and talk to us about improving our service. And so we held just 4 sessions, one every fortnight on Zoom. And it was just half an hour per session. And we had 6 patients. And we had also, we invited everybody we can think of in terms of staff, so not just doctors, but also the lady who answers the phone, clinical nurse specialists. So we invited everybody we could think of, and not all of them turned up, and not everyone turned up at every session. But we used mapping, we used a good old online Wardley Maps Live to start to construct a map of how we saw the service at this time, and this was earlier this year. So so this is how we at that time saw what we were talking about. And just to briefly go through what this map is describing in terms of the conversations that we had over that time. So the users that we wanted to focus on were patients with giant cell arteritis, and one thing they really need is treatment, because we want to prevent blindness and stroke, and we want to sort of improve their health. So there's a whole lot of those things inside treatment, but treatment depends, and treatment is corticosteroids is a mainstay of treatment, and those are very cheap. They're universally available. GPs can prescribe them. And so that's something that's very, very standardized and guideline mandated. And similarly, diagnosis is pretty standardized. It's described very well in the guidelines how we should do that diagnosis. There's lots of evidence about that. So from our perspective on the service, we thought that was sort of nearly in commodity, following the work that we'd done in terms of introducing ultrasound. Treatment also needs monitoring, because I told you about the side effects of corticosteroids. They are manifold. They all need monitoring, and that's also a core part of what we do, and is really, really important as well. And we can't really treat unless we can monitor for the side effects of that treatment. That's one of our responsibilities as medics. We also have a lovely system of follow-up appointments with hospitals. So in order to continue on treatment, patients need to come back for their follow-ups. But there's also some dependencies under here, and particularly as we get into this monitoring phase, this long-term treatment, other aspects of the infrastructure start to become important. And patients were telling us about the importance of their clinicians who are looking after them and maybe dealing with different organ systems. Some of those side effects of corticosteroids do affect different specialties, and their GP may very well be involved with almost all of them. But how do these people communicate in a timely fashion and share the information which is relevant in the appropriate way? And we have systems for doing that, with really strong rules about confidentiality and how we do that sharing. But partly because of the complexity of the rules about this, it's not always as efficient or timely as we would like, and they really felt that was an area which needed to be highlighted for something that we need to think about how we would improve that. They also told us about how, well, it's important that if there's a change from the patient perspective, they are able to communicate with the hospital. Then there needs to be a little bit of two-way communication. So not just the hospital sending texts, but the patients, if they needed to get hold of us, how would they do that? And we have systems in place in our clinical service for that. It's called our inquiry line in rheumatology. And they talked about their experiences of using the inquiry line, and some areas where it worked really, really well, and also some areas where it might improve. And then there was something else about continuity of care. So whether you were able to see the same doctor or the same team, and really get some continuity as you continue to manage this long-term health problem, and not just in secondary care, but also in primary care as well. This is really, really important to patients as they expressed it, and also makes our life easier as doctors. If we know our patients, it's a lot easier to come up with a coherent treatment plan and adapt that over time as is needed. On the left-hand side of the Wardley map, we had some really interesting conversations about education. So education can be a bit problematic word if misused. So sometimes when we talk about patient education as clinicians, what we really mean is getting patients to do what we think they ought to be doing. And when patients talk about doctor education, as they often do between themselves, they are often talking about how we get doctors to do what we think they should be doing. And there's a tension there, and it's really important that we have shared decision making, and that we take a really holistic view of what that education means. It's not just transmission of information, but it's all about understanding what this condition means for you as a doctor or a patient, and what the implications are for all sorts of things. So that patient education, the patients in our group are saying, well, actually, we don't just go to you guys in the health service, but we have groups, and we know people who have had relevant experiences, and we talk to them. That's our choice. And we might also go onto internet forums, and for some people that is a lifeline. So and they said, it's really, patient education is really important. And also, in order to get good education from healthcare providers, those doctors need to be educated. And many of our patients took a little bit of a while to have their disease diagnosed, and that often raises questions in their minds about, well, how much do doctors actually know about my condition, particularly if it's a rare condition? Is there a need for better medical education about this condition, given that it can present to any doctor, and everyone needs to recognize it, and yet it's rare? So how do we keep doctors aware about some of the less typical manifestations about the disease, so it can be diagnosed early to prevent blindness and stroke? So that's a really important thing, that medical education, and that's really kind of on us as clinicians to educate each other about this. And then what also patients talked about was support, and a lot of that is practical support from friends and family in their lives. And in order to do that, friends and family have to understand about the disease, and really because this disease is often not very well understood in the general public, there's low public awareness. This was a real issue for many patients, and that education for friends and family was a real unmet need for them, which we talked about were difficult really for one small clinical service in Leeds to change the world on that, but something that is really important for us to be aware of that and aware of the gaps there that we needed to be aware of in designing our service. And there was something about research as well, because research definitely drives medical education. It really helps raise awareness of diseases, and it helps us understand more about sort of best practice in a disease, and really it can be an instrument for service improvement as well. But then also just understanding what causes the disease, even without having the better treatments in place yet, actually makes a really big difference to patients, because it helps them understand what's going on with them, which helps them make choices about their life as well as about their treatment. And that was felt to be something that they would love to be better advanced. And so that kind of research side of things, we were surprised, because we thought that patients were going to be all about, well, you know, we want something now, we can't wait for research. But actually, there was a vocal minority who were very passionate about the importance of research, and that was great for me, because it really helped validate the fact that I do spend half my time on the academic side of this, but also really important to hear about their perspective about where research sits in terms of actually having impact on patient health. But there was a general agreement across patients and staff that really where we needed to prioritize was diagnosis, treatment, monitoring, and that maybe monitoring would be something that ought to be where we need to be going next in terms of our service improvements. So we've been taking that monitoring and expanding that map and looking at what that means. But just briefly, just talk about, from my perspective, how I feel that this impact mapping has made so far for us. It was a really nice technique for keeping the user needs front and center in talking about the clinical service, so that we don't kind of go down rabbit holes about particular people's priorities, but we can sort of really kind of have these discussions, and it enables communication between people who have different perspectives, and also to an extent talk different languages, because we have highly technical clinical language and we have the language patients use. And being able to use the map gives enough abstraction, if you choose the words correctly, that you can often get some quite sophisticated levels of communication about how these things fit together, that it becomes possible. And the mapping process also helps us as a team choose appropriate methods for how we're going to do things. So research, so things on the left which are highly novel and innovative, all the way through to audit, which is where you're implementing guidelines, you're pretty sure that you're doing the right thing because there's strong evidence. And how are you going to use that audit to drive improvement? And this is particularly relevant to the monitoring. And we've been working with some of our team to design audits and projects to focus on particular elements of monitoring to drive improvement in those areas. On the research side, mapping's also had influence on the research part of my job. So for example, scoping out contentious problems. Often we work in very diverse teams. So for example, I was involved in a group mapping out mapping out our ICD codes for age-related pathologies, and I was in the immune aging group, and we are talking about should there be a code for immunosenescence, and we used Wardley mapping with clinicians and people who worked on cells and bioinformaticians and very technical people to talk about that space and think about, well, what utility would this code provide, and what are the dependencies, what's the value chain there? And that was quite a helpful focus for some of our discussions. Mapping has evident utility in delivering clinical trials, which are like research mini worlds. This is my mini worlds picture on the right, where you have to construct a sort of world that is that works as within its boundaries, and has very clear documentation and a protocol, and everything has to fit together, and there have to be flexibility where there needs to be flexibility, but rigidity where there needs to be rigidity. And so designing and delivering those trials, mapping is quite useful for some of that. And I've also found it to be very useful in discussing particular spaces with some of our academic trainees who are doctors who are interested in pursuing academic careers, who have been talking about the the unmet needs, the who are the users, what is the value chain, and where do we want to focus? Where does the priority for a research study need to sit? So we've been using mapping in different contexts to map out different problem spaces there. So I would like to thank you for your attention, and I'm going to stop sharing my screen, and I'm very happy to have any questions.
Well, first of all, thank you so much. I've got a bunch of questions in two areas, which, first of all, you took mapping into the wild and started talking to non-mappers about it, and you appear to have had some success. So I want to dig into that. I'm also really interested as to how this can be, I suppose, scaled outside of the specific context you're in. We do have a hand that was raised, William Henry, right at the beginning. So I can allow William to talk, which I've just done. So, William, if you have a question or wanted to raise it, please go ahead. While I'm waiting for you to do that, yeah, just tell us a little bit about the success you've had and what you think is necessary to sort of scale this out in terms of both your approach and then also to get the same sorts of results.
So I've given a version of this talk to people from the board of our trust, and they were quite surprised because they said, "Oh, we thought Wardley mapping was for IT, and you've been using it for like doing the core business, doing our core business as a trust and like improving service and research." And so they were interested that this could be adapted to a wider context. And I was kind of surprised that they were surprised, because of my experience of the healthcare mapping project. I've been spending all these hours chatting with other people and using mapping to map out healthcare systems and clinical trials and clinical decisions. And so to me, it's like, oh, well, of course you can. But because they had come across it in this IT context, they had thought of it as like an IT method. And so that conversation, that was only a few weeks ago, that's been quite interesting. And I'm also, because some people who have been involved with this have been, oh, this is a great method, I'm going to use it. Other people have been, oh, this is okay, but I don't think, I don't think it's for me right now. So I think it depends on how your mind works. And if you've been involved in mapping, that's when you may decide to do it for yourself. And I think there's that kind of, you have to experience it to really understand how it might be used. One day, it would be lovely to develop some training sessions to my, rheumatology community about how to do this. I don't think I'm quite ready for that right now. I think, doing it on small scale, having different people try in different contexts and just getting some more experience of it in this context would be really useful before that big scale up happens. Because what you don't want to do is just go, oh, this is another training course on this funny technique that has got all these different words, and we don't really see the benefit. You have to kind of get into it and do it.
There is an emotional on-ramp, shall we say, in terms of understanding what is this for and how does it help me.
Yeah.
I wonder, do you think the context, right? So you're talking to patients, people who have an illness. I am familiar with a horrible autoimmune condition, and just, you talked about rarity, and how that may be, that level of individual commitment may be stigma. So I was wondering, while you were talking, which other domains might we find contributors to a map who are suitably motivated like that? Is there a way we can use that as a model and kind of identify where your lowest hanging fruit are in terms of sort of driving for the mapping window?
Because I guess people need to show up to the mapping session. That is the minimum. So they need to care enough that they will show up. And I think curiosity is quite powerful. So there are ways of presenting things that are not scary, that don't look like, oh, we're going to do a facilitation technique, we're going to use this tool, but to just to start just getting into it. And I think that there will always be people who it's not their priority to contribute to discussions about how to make things better, but actually quite a lot of people do, and people may not themselves want to do it, but with their own lived experience, but they may have other reasons for wanting to get involved. And we sort of haven't really had a problem with finding patients to take part in things like this, but that is partly because of our, I guess, because our history of patient public involvement and research has kind of given us that that infrastructure to make it feel safe to do that. And perhaps that's partly why this has worked, because we already have this structure in place of patient and public involvement. We have this philosophy, and we've got this long history of involving patients and public. And so patients and public are able to take part because they know what to expect, they know us, they kind of feel safe to do that. Because if you're taking on a new technique and then you're putting yourself out there, that's quite confronting, isn't it? If you are just a standard member of the public who has never so that then becomes tricky. So it's thinking about what makes it easy for people to take part and gives them the choice to take part. And some people might turn up at the first session and not come back, but actually our patients did come back. It was the staff that sort of was in and out a bit because they were so hard pressed on time, but the patients, they committed and they turned up and they stayed coming. It was amazing.
There is another side to this. In when I think of my experiences with the NHS, it's the biggest help I needed was this demystification, understanding what the process is,
Yeah.
what it should be, what's actually happening, and why. So I can understand also why a mapping process for a patient might be interested in just understanding why did this happen, why does this keep happening. So that's an extra, I suppose, level of motivation or you've got to get.
And understanding how it works at the back end is really important, because if you're trying to get help from a service and you don't understand like the routine, who talks to who, how that happens, what everyone's roles are, who you're talking to on the phone, if you can understand that, it's easier to get help yourself. So absolutely, there's motivation in understanding how all this works on the inside for being able to access help yourself if you need it, and to support other people in accessing help as well, because people are in groups and communities and families and friends, and often understanding from their perspective how things work for us is quite helpful. And it also helps with expectations on our side. If they understand how stuff works, then people have the reasonable expectations about what they can expect from us if they use different routes.
Oh, fantastic. In terms of your journey with this, right? So you've had one project, it's taken a couple of years, you've got some metrics, and you've got some measured improvements. So where do you take this next?
So I think the next bit is, as I said, we're sort of setting up a few sort of mini projects to look at how we can improve our monitoring of patients. There is a dependency there in terms of data, because a lot of traditional audit and improvement work is very data intensive, because we're using healthcare data, secondary uses of healthcare data, and it's very laborious, and you have to go into individual records and extract, and it takes hours and hours and hours, and someone has to do that, and no one wants to do that because it's like kind of boring. You're not talking to people, patients, you're kind of going into history and extracting these variables, and it's dull. And if we had better ways of using the data which we're collecting, then we could accelerate a lot of these processes. So we're doing some mini projects which are manageable in terms of the workload of doing it the traditional way, but we're also looking at whether we can improve the data side of what we collect about our service within our everyday care. Because if we can sort that out, then we can potentially accelerate improvement in the future, so that it's not quite so much a labor of love to collect these quality data, but it just happens automatically. But in order to do that, you have to understand what's important to patients and to clinicians, and to really prioritize what gets collected, how that quality is mandated. And so there's all sorts of stuff behind that in making sure that the data that is collected for improvement purposes is the right data, that's high quality, that it's shareable. And so that is something that in parallel I'm looking to work on. And in the process, our hospital is, of course, has a continuous improvement philosophy, and digital is a massive priority for our hospital too. It has an in-house patient record, which is amazing. So it's got in-house coders who are constantly looking to develop and improve that software that we use, that we depend on for everything. So it's how we work within that within that structure, which is something that's quite unique to us. We don't have an external software provider for much of what we do. A lot of it, what we do, is developed in-house. So there's that too. There's that dimension of it, as well as the data side of it, which is not an easy win. It's not a quick win. And we have to make sure that what we're doing is worth it, that it's worth the effort and investment of putting in to develop, to improving those systems.
I've been allowed to monopolize questions. It's 8:45, and then we're at the end, but I'm going to ask just one really quick one, which is the disease you picked, giant cell arterio. I can't remember the full word, but that's going to make me click and have a look at that anyway, just giant cells. So I'm curious as to this question: is there a critical mass in terms of the number of people who have the disease, right? So in terms of collecting useful information as to what is going wrong in terms of the variance from one person to another. Autoimmune conditions can be quite different from one region to another. So do you think there's a critical mass of people you need involved in order to get to a useful place after, from going down and walking mapping and collecting?
I think it's maybe not numbers, but diversity is important. So we were very conscious. Many autoimmune diseases affect women more than men, but that has consequences if you happen to be a man with this disease, and that's not unusual. Maybe 66% of people are female, so with this disease are female. So men get the disease too, but they're often find it hard to take part in this kind of mapping exercise. But it's really important to get that we wanted to get as many men as possible to balance out, have a gender balance because men and women have very different ways they experience and use healthcare services often. And we want to get diversity in terms of not just the very sort of typical retired professor who wants to take part in something like this, but people from all walks of life and people with all different sorts of experience. It's really important that we have that diversity as well. And you can get huge amounts of value, particularly if you are involving people who are connected with other people who have that condition. So there's often support groups or charities or informal networks and people who know people. So even one person taking part who has talked to other people and is able to communicate perspectives other than their own, they can be really, really valuable. So even with ultra rare diseases, I really, really think, and especially for ultra rare diseases, because otherwise you just get the clinicians talking about what they think patients need, but they don't really know, because they don't have that huge, those big data sets that they would like, so they make assumptions. So it's really important to challenge those assumptions. And the rarer the disease, the more important, in a way, I think the patient involvement is, because the less we know. So as clinicians, if we're missing things, we don't even know we're missing things. And unless we involve patients, we will not know that.
Dr. Sarah Mackie, we're at time. That was truly fantastic. Thank you so much, and congratulations on winning an award for this, but also getting to this particular point. You and I have discussed the potential for you to do a talk just on the human element, and I'd really look forward to hearing a little bit more about that. I'm not surprised to hear it was Simon's idea to include me, because it need to be somebody with a bit of a masochist streak. But no, well done. And that's really impressive.
Thank you.
Thank you again. I'll close the room now.